Hello everyone, this is Shanmugapriya. This video lecture is on the topic Tetrology of Fallot. Let's get started. The contents: definition, etiology, embryology, pathophysiology, clinical features, diagnosis, X-ray features, treatment, and a clinical case. Guys, I have added a clinical case at the end of the lecture. Recently, all the examinations have been shifted from the pattern of one-liners to clinical conceptual questions. So, it is very important for every medical student to know, to be able to solve the case, clinical case, and get to the answer. So, to make things better and easy, I have added a clinical case at the end of the lecture. So, now the definition. As the name suggests, tetralogy. Tetro means four. Tetralogy of Fallot. This tetralogy of Fallot has four components. Tetralogy of Fallot is defined as simultaneous occurrence of the following defects: subpulmonic stenosis, right ventricular hypertrophy, ventricular septal defect, and an overriding aorta. So, let's look at the etiology. Tetralogy of Fallot is the most common cause of cyanotic congenital heart disease, almost like 4 in 10,000 live births in the US. The etiology is typically sporadic, sometimes associated with genetic defects like Down syndrome or DiGeorge syndrome. It is also associated with other cardiac anomalies in 40% of patients. So, here is a brief embryology so that we can understand the concept more easily and we can recollect all the four components of tetralogy of Fallot. Here, we start with two primitive heart tubes which fuses cranially, and further it proliferates and produces one heart tube which has an outflow tract called truncus arteriosus, and there's an inflow tract that is the sinus venosus. From where the blood enters the heart is the sinus venosus, and from where the blood leaves the heart is the truncus arteriosus. And there are furthermore components which proliferate and develop into the ventricles and atria later on. Truncus arteriosus gives rise to two main components, that is the aorta and the pulmonary trunk. So, the here, the neural crest cells which migrate to form the spiral septum, which divides this tube or the heart into the two halves, the right and the left half. If the spiral septum is placed exactly at the center, the normal development of the heart happens. If the spiral septum is anteriorly displaced, then the tetralogy of Fallot is given rise. What happens when this spiral septum is anteriorly displaced? When the spiral septum is anteriorly displaced, there is less space for the pulmonary trunk and there's more space occupied to the aorta. This less place causes subpulmonic stenosis. So, in tetralogy of Fallot, there is no defect in the valves, but there is actually subpulmonic stenosis, that is narrowing of the pulmonary trunk, and there is widening of the aorta. Here is a brief diagrammatic description of the heart after the defect. That is, you can see a narrowing of the pulmonary trunk in the blue, and that causes a pulmonic stenosis and an overriding aorta, which is broad, and there is a ventricular septal defect. Because of this ventricular septal defect, there can be a murmur, a shunt murmur can happen here. But before that, let's see what brief physiology. So, because of the subpulmonic stenosis, the right ventricle has to pump blood more effectively because of the pressure and obstruction. So, there is increased pressure in the right ventricle. Due to the increased pressure in the right ventricle, there is hypertrophy of the right ventricle. Because of this, the right ventricular pressure increases more than the left ventricular pressure, so there is a flow of blood from right ventricular to the left ventricle, and it flows into the and aorta. But the main concept here is, and on day 0 of the birth of the child, there is no cyanosis. Why? There is no cyanosis because the ductus arteriosus is still patent between the aorta and pulmonary trunk. So, therefore, when the blood flows into the aorta, there is a pulmonary dependent, ductal dependent pulmonary circulation happening, and still there is blood flowing to the pulmonary, a little blood is flowing to the pulmonary trunk into the lungs. So, there is no cyanosis on day zero of the birth of the child. But on day 7, when this ductus arteriosus closes, cyanosis starts. Then we can see the symptoms of cyanosis in the child. This is the main concept, and therefore we have covered all the 4 points, that is, subpulmonic stenosis, overriding aorta with a ventricular septal defect, and right ventricular hypertrophy. So, next, let's see the pathophysiology. The extent of right ventricular tract obstruction and central pulmonary hyperplasia determines the severity of hemodynamic dysfunction. In case of mild obstruction, there is left to right shunt via ventricular septal defect and there is no cyanosis. In severe obstruction, there is right to left shunt via ventricular septal defect and therefore there is severe cyanosis. Next, let's see the clinical features. The clinical features, mild cyanosis. There is no cyanosis on day 0. Cyanosis occurs only on day 7. There is TET spells. TET spells are nothing but intermittent hypercyanotic hypoxic episodes with a peak incidence of 2 to 4 months after birth. They are associated with physiological and physical stress, especially like crying or feeding. Untreated children tend to squat. Why children squat? Squatting will cause the compression of the femoral artery, which increases the peripheral resistance, which in turn increases the left ventricular pressure. So it causes a reversal of shunt right to left to from right to left to right. Auscultatory findings. Shunt murmur is negligible. We can hear a flow murmur. It is best heard at Erb's point and left upper sternal border. Next, let's see the diagnosis. Diagnosis can be achieved when we check for the pulse oximetry. There's decreased oxygen saturation due to decreased blood supply to the lungs. We have to do a hyperoxia test to distinguish cardiac from pulmonary causes of cyanosis. In ECG, we can see a right axis deviation with right ventricular hypertrophy. P pulmonale can be seen with increasing age. The indication of choice for tetralogy of Fallot is echocardiography. In echocardiography, we can detect the main features of tetralogy of Fallot. We can also do a quantification of right ventricular outflow tract pressure gradient. X-ray. The X-ray features are very unique. With there is pulmonary oligemia or there's a black lung because decreased supply of blood. Next is a boot-shaped heart or it's also called cor and sabut. Due to right ventricular hypertrophy, there is upturn of the apex of the left ventricle. And there can also be right-sided aortic heart in 30% of cases. So, the treatment. In case of severe right ventricular obstruction, outflow tract obstruction, we give IV prostaglandin. IV prostaglandin until surgery. IV prostaglandin will maintain the patency of the duct of ductus arteriosus. So it is important for us to give IV prostaglandin and to keep the duct patent. And for acute hypoxia and TET spells, we administer oxygen. Knee to chest position or squatting position can be done. IV morphine for sedation and fluids. If above measures fail, we go for IV beta blockers. The main treatment is surgery. Temporarily, we can do a Blalock-Thomas tossing shunt or BT shunt. One branch of the subclavian artery or carotid artery is separated and it is connected with the pulmonary artery. This is a temporary procedure which is used to increase the pulmonary blood flow. Later on, cardiopulmonary bypass is performed. The aim of the surgery is to close the ventricular septal defect, resect the area of infundibular stenosis, and relieve the right ventricular outflow tract obstruction. So this was the treatment. So guys, let's see the clinical case. A 5-year-old male is adopted from an orphanage in Eastern Europe and brought to the US by his new parents. He is small for his age and has a bluish hue in his lips and tips of his fingers. He has clubbing and spells of cyanosis when he is squatting. A systolic ejection murmur is heard in the left third intercostal space. A chest X-ray shows a small heart and the diminished pulmonary vascular markings. A EKG or an ECG shows right ventricular hypertrophy. So the answer for this, the answer for this is it's tetralogy of Fallot. How can we come to the conclusion of tetralogy of Fallot? Is they tell the baby is cyanotic and he's having a systolic ejection murmur. There's also a pulmonary hyperplasia with a right ventricular hypertrophy. These keys will lead us to the answer that it is tetralogy of Fallot. So, guys, that's that's it for this lecture. Thank you all for watching. Please do like, share, and subscribe to my channel so I can make more medical related videos. And have a wonderful day.